So persistent fetal vasculature, and my talk is say yes to surgery. Persistent fetal vasculature is a developmental malformation caused by failure of the fetal hyaloid vascular complex to regress. It can either be anterior, posterior, or combined. Anterior persistent fetal vasculature encompasses a wide spectrum of findings ranging from persistent tunica vasculosa lentis, a Mittendorf dot, central retrolental membrane, a complete thick retrolental membrane, traction on ciliary processes, and it can also be associated with other abnormalities. In posterior persistent fetal vasculature, the hyaloid stalk is still present, attached between the optic nerve and the lens, causing traction, anteroposterior traction on the vitreous and the retina, and may lead to traction retinal detachment. The photo on the top here shows the brittle star appearance, which is characteristic of the stalk, causing traction and retinal folds around the optic disc. There could be retinal folds, retinal dysplasia, optic nerve hypoplasia, and other abnormalities. There's also combined anterior and posterior persistent fetal vasculature with features of both anterior and posterior type. You may have retinal fold, retinal detachments can be either tractional or rhegmatogenous, and the photo here shows a combined case with a stalk attached to the back of the lens and also remnants of tunica vasculosa lentis. So what are the sequelae of persistent fetal vasculature? All these sequelae are related to traction on ocular structures, which can be, again, anteroposterior traction in the presence of a stalk, which can cause tractional retinal detachment, and also circumferential traction caused by a retrolental membrane pulling on the peripheral retina and the vitreous base, causing either tractional or rhegmatogenous retinal detachment. It can also push the lens forward, causing shallowing of the anterior chamber, cataract, elongation of the ciliary processes, which reduces aqueous humor formation and hypotony. On the other hand, you can also have glaucoma and therefore dense amblyopia. Angle closure glaucoma results from contraction of the fibrovascular tissue behind the lens, causing anterior displacement of the iris lens diaphragm and peripheral anterior synechiae and posterior synechiae. And the blue arrow here points to the presence of peripheral anterior synechiae, which can be seen gonioscopically. So the question is, should I operate on persistent fetal vasculature cases? Well, with our better understanding of the pathogenesis of persistent fetal vasculature, together with our improvement in diagnostics and also the improvement of surgical techniques, I think the answer should be yes. We can obtain visual improvement in the anterior type up to 6/18 vision, and in the posterior type, counting fingers or even light perception is good because it's important to maintain the normal sleep-wake cycle of the patient. But the most important thing is to halt the traction, to stop the traction, which results in reduction of complications such as retinal detachment, glaucoma, hypotony, removal of significant media opacities, and a good cosmetic appearance. The incidence of Sisk and his co-workers in 2010 showed that the incidence of progression to complete blindness is higher without surgery, and that the visual outcome is superior in cases that underwent surgery. This is a study coming out of Bascom-Palmer. So, when not to mess with persistent fetal vasculature, I think the most important thing is if you have combined pathology, microphthalmia with axial length less than 14 millimeters, or a disparity more than 3 millimeters between two eyes, and absence of visual axis opacification. I'm showing you here some of the videos. This is a retrolental membrane with vessels, but actually most of these vessels are ghost vessels that don't bleed. After removal of the lens, the vitreous cutter is used to remove the retrolental membrane. There was also a stalk that fell back. This is a second case with one of the very few cases that had a really densely vascularized retrolental membrane, where after removal of the lens by aspiration with the vitreous cutter, I left the anterior capsule intact and then performed endocautery for the blood vessels, which were really looked very ferocious and patent. And then the vitreous cutter was used to remove the retrolental membrane without causing bleeding. And once the membrane was removed, then the anterior capsule itself was removed in order to decrease the turbulence in the anterior chamber during the procedure. This is a case with a stalk where after performing the lensectomy, and the anterior capsular removal. The stalk was removed with scissors. It took a bit of time to cut it actually because it was a very thick stalk, but finally it was cut, severed, and then the vitreous cutter was used to remove the head of the stalk and part of the stalk, and the stalk then retracted posteriorly. This is the last case I'm showing. This is, again, I always take a look at the angle to look for synechia. This was done through an anterior approach. 2 MVR blades were used. Viscoelastic was introduced in the anterior chamber, and you could see that the lens had been pushed so far anteriorly that it was adherent to the back of the cornea. Synechia were removed by blunt dissection with viscoelastic, and this was followed by removal of the dense membrane, retrolental membrane, with the vitreous cutter. And once the membrane was removed, then you can see here I'm using the irrigation cannula, half a minute, just half, in order to help me enlarge the pupil. And then the membrane was cut using scissors in multiple places to cause retraction of the ciliary process back and to prevent contracture. Thank you very much, and I'll give my opponent a chance to show us something else.